Usually a medical diagnosis is, it's pretty binary. You break your arm, the x-ray shows this jagged white line, and the doctor just points at the screen and says, well, there it is, broken.
Right. Yeah, it's clean. But the problem is incredibly obvious, and the solution is basically to just cast it and let the body do the work.
Yeah, exactly. But step into a reconstructive and plastic surgery theater, and you aren't just a doctor reading an x-ray anymore. I mean, you are an architect trying to rebuild a demolished house while the foundation is literally still on fire.
That's a great way to put it. It's a massive, high-stakes logic puzzle.
And that is exactly our mission for you today. You asked us to help you study the MRCS IV book, specifically the Part A, 6th edition chapter on plastic surgery. And we want to do this in a really detailed but highly organized way.
Because you need this to be clear, right?
Yeah.
And you want it to be highly memorable for your exam prep.
Exactly. We are building a mental map for you in this deep dive.
Which means moving beyond just, memorizing a stack of flashcards. Plastic surgery isn't just about aesthetics. It's this profound challenge of matching tissue biology to environmental needs.
Right.
So to understand the complex solutions, the grafts, the flaps, the intricate closures, we first have to thoroughly understand the exact nature of the problem. We have to know the specific enemies of the skin.
You got to evict the termites before you rebuild the living room. Right. Okay, let's unpack this. Let's look at the first part of this chapter, which covers the major malignant skin lesions.
The threat matrix, basically.
Yeah, the threat matrix. So if I'm looking at the text, the two big ones that share some initial real estate are basal cell carcinoma, or BCC, and squamous cell carcinoma, SCC.
The big two.
Right. And they both seem to show up in sun-exposed areas, and they both aggressively target immunosuppressed patients.
Yeah, that is their baseline similarity. But chemically and behaviorally, they're radically different. Well, the text describes BCC as a classic nodular lesion. It's typically pink. It features this distinct rolled ulcer, and it's surrounded by tiny dilated blood vessels. They're called telangiectasias.
Telangiectasias. Got it.
Yeah.
I always visualize BCC as like a lazy squatter.
The lazy squatter. I like that.
Yeah, it grows incredibly slowly, just kind of taking over the local neighborhood. But the most crucial thing the text emphasizes for the exam is that BCC rarely, if ever, metastasizes.
Right. It almost never spreads.
But wait, why is that? If it's a cancer, why doesn't it spread to the rest of the body like other cancers?
It actually comes down to its biological dependency. BCC cells are highly dependent on their surrounding stroma. That's the connective tissue they grow in.
Oh, interesting.
Yeah, so if a few BCC cells manage to break off and enter the bloodstream, they usually just die. They don't have that specific supportive local environment to sustain them elsewhere, so they just stay put and slowly destroy the local tissue.
Wow, so literally a lazy squatter that refuses to leave the couch.
Exactly. But then the text pivots to SCC, squamous cell carcinoma. And if BCC is the squatter, SCC feels much more like an aggressive vandal.
An aggressive vandal, so it moves fast.
Highly aggressive. Visually, SCC presents as red, crusted, scaly, or keratinizing. And unlike BCC, SCC can, and absolutely will, spread to the lymph nodes.
Okay, so a much bigger threat.
Definitely. But what makes SCC fascinating for an exam scenario is where it actually comes from. It frequently arises from pre-malignant conditions.
What kind of conditions?
The text highlights Bowen's disease, viral triggers like HPV, and, this is a classic board question right here, chronic wounds. Specifically, something called a marginal ulcer, developing in an old burn scar.
A marginal ulcer. I've always struggled with that mechanism, to be honest. Why does an old burn scar suddenly breed cancer decades later? I mean, what's happening there?
Think about the vascular reality of a severe burn scar. It's this thick, fibrous tissue with a really terrible blood supply.
Right, mostly just scar tissue.
Exactly. Because the blood supply is so poor, your body's immune cells, the white blood cells that constantly patrol your body for mutated cancerous cells, they just can't easily access the area.
Oh, wow.
Yeah. So you combine that severe lack of immune surveillance with the chronic inflammation and constant cellular turnover of an unhealed wound. It creates the perfect isolated laboratory for a malignancy to just mutate unchecked. That is what a marginal ulcer is.
That makes so much sense. It's like the roads are so poor that the police can't patrol the neighborhood, so crime just takes over.
That's a perfect analogy.
Okay, so that's the squatter and the vandal, but the third major threat in this chapter seems to break all the rules. Melanoma.
Well, melanoma, it's the most dangerous of the three by far. And counterintuitively for a skin cancer, melanoma often prefers non-exposed areas of the body.
Which is wild.
It is. To identify it, the text uses the classic ABCDE checklist. You're looking for asymmetry in two axes, border irregularity, color changes, usually brown, black, or pigmented, then a diameter greater than 6 millimeters, and evolution, meaning the lesion is elevating or enlarging over time.
But wait, if BCC and SCC are triggered by the sun hitting exposed skin, why on earth does melanoma hide in areas where the sun doesn't even shine?
Right, it seems backwards. But it's because melanoma etiology is vastly more complex than just cumulative UV radiation.
Okay.
While a BCC is often the result of, decades of chronic sun exposure on the face or hands, melanoma is heavily tied to genetic susceptibility, like BRAF mutations, for example. And it's linked to a history of intermittent intense UV damage.
Like severe sunburns.
Exactly. Think severe blistering sunburns in childhood rather than just working outdoors every single day.
Yeah.
The melanocytes themselves are distributed all over the entire body, so once that genetic switch is flipped, the malignancy can appear anywhere, even on the soles of the feet.
Wow. And the surgical approach for melanoma is wildly different, too. I'm looking at the excision margins in the text, and it's just this dramatic escalation.
Yeah, what's fascinating here is that everything regarding melanoma surgery hinges on one single metric, the Breslow thickness.
Breslow thickness.
Yes, this is the precise microscopic depth of the lesion.
But why does the depth completely dictate the width of the surgeon's scalpel? Why do the margins get so wide?
Because the skin isn't just a flat piece of paper, it's a three-dimensional matrix. As a melanoma grows deeper, it breaches the basement membrane and pushes down into the dermis.
Right, hitting the deeper layers.
And by doing that, it gains access to an increasingly dense, complex highway of lymphatic channels and blood vessels. So a deeper tumor has a geometrically larger radius of microscopic, completely invisible spread.
So the margins have to scale aggressively to catch it all.
Exactly. Just to compare, for a non-metastasizing BCC, the text states you only need a 3 to 5 millimeter surgical margin.
Pretty small.
Right. For the more aggressive SCC, you take 4 to 6 millimeters, plus maybe checking the lymph nodes. But for melanoma, the Breslow thickness dictates a strict sliding scale.
Let's hear the scale.
And in situ melanoma, meaning it hasn't invaded the deeper layers yet, requires a 0.5 to 1 centimeter margin. If the Breslow thickness is less than 1 millimeter, you take a full 1 centimeter margin.
Okay.
If it's 1 to 4 millimeters deep, you need a 2 centimeter margin. And if that tumor is deeper than 4 millimeters, the surgeon is taking a margin greater than 3 centimeters.
Greater than 3 centimeters, which is a massive piece of tissue to remove.
It really is.
This highlights the absolute critical nature of the biopsy, which is actually the next major focus of the chapter, the diagnostic toolkit.
Right, because you need to know what you're dealing with before you cut.
Exactly, because if depth is the whole ballgame for melanoma, how we sample the lesion becomes a literal life or death decision. I look at this toolkit like a crime scene investigation.
Yeah, I like that.
Yeah, like you don't use a massive backhoe to brush for delicate fingerprints, and you don't use a tiny magnifying glass to dig up a concrete foundation.
That analogy perfectly tracks with the strict rules the text lays out for the 4 main biopsy tools: shave, FNA, TrueCut, and excisional.
Let's start with the shave biopsy.
So this is where a surgeon literally slices a thin layer off the very top of the skin. It is strictly reserved for benign superficial lesions. The prime textbook example here is a seborrheic keratosis.
Oh, those are the lesions that usually show up on the trunks of elderly patients, right?
The text describes them as having a, quote, raised waxy or greasy scale. Because they sit entirely on the surface and they are definitively benign, a shave biopsy or even freezing them with cryotherapy is perfectly appropriate.
Yeah, that makes sense.
But you would never, ever use a shave biopsy on a suspected melanoma.
Right, because you ruin the evidence.
Exactly.
If you shave off the top half of an asymmetrical, irregular lesion, the pathologist physically cannot measure the true Breslow thickness. You've completely blinded the surgeon to how wide their eventual excision needs to be.
You compromise the staging, which in turn completely compromises the patient's survival odds.
Wow. Okay, so what about the deeper tools, the FNA and the TrueCut?
Well, FNAB stands for fine needle aspiration biopsy. You use a very thin needle to pull out a tiny cluster of cells.
Just cells, not a chunk of tissue.
Right. This is primarily used for thyroid lesions or to check enlarged lymph nodes to see if an SCC or melanoma has actually metastasized there.
Okay, and TrueCut.
If you have a massive, deep-seated lesion, the text lists things like breast masses, thigh masses, or retroperitoneal abdominal masses, you need to see the tissue architecture, not just isolated cells. That requires a TrueCut, also known as a core biopsy. It takes a solid cylindrical tube of tissue.
Leaving us with the excisional biopsy, where you basically just cut the whole thing out from the start.
Yes, and this is mandatory in two specific scenarios. First, for small, completely benign lesions like a sebaceous cyst, it's small enough that you might as well just cure the patient while diagnosing them.
Just get it over with.
Right. Second, and this is crucial for the exam, an excisional biopsy is the initial diagnostic step for any suspicious melanoma. You excise the entire visible lesion with a tight 2 mm margin.
Wait, just 2 mm? But you said earlier the margins for melanoma are huge.
Right, but this is just the biopsy. You do a 2 mm margin just to get it under the microscope completely intact.
Oh, I see.
You measure that Breslow thickness and then bring the patient back for the definitive wide 2 or 3 centimeter surgical margin later based on what you find.
Got it. Okay, so the tumor is correctly identified, perfectly biopsied, and fully excised. The cancer is gone, but now the surgeon is staring at a physical defect, a hole.
The hardest part.
This brings us to the core reconstructive logic of the chapter. The text draws a massive line between two major concepts, grafts and flaps. Here's where it gets really interesting.
This is where the architectural puzzle really begins. So let's define a graft first. A graft is the transfer of tissue from one site to another entirely without its own blood supply. You sever it completely.
But wait, human tissue is incredibly hungry for oxygen. If you cut off a piece of skin, completely disconnect its blood vessels, and plop it onto a wound, why doesn't it just instantly undergo necrosis and die?
Because of this amazing three-step survival mechanism. And it's exactly why grafts require perfect wound soil, so to speak.
Okay, what are the steps?
First is imbibition. For the first 48 hours, the graft acts literally like a sponge. It physically drinks in nutrients and plasma oozing from the recipient wound bed.
Just soaking it up.
Yeah. Second is inosculation, where the severed capillaries in the graft actually align and connect with the capillaries in the wound bed.
Like connecting pipes.
Exactly. And finally, angiogenesis occurs. Entirely new blood vessels grow right into the graft. But this miraculous process only happens if the recipient bed is highly vascularized, perfectly clean, and free of infection or radiation damage.
So the soil has to be pristine. And where are we getting this skin from? The text mentions a few distinct origins.
Yeah, and this origin terminology is classic exam trivia. An autograft is tissue moved from one spot to another on the same person. An isograft is tissue shared between identical twins.
Okay.
An allograft is from another human, like a cadaveric transplant. And a xenograft is tissue from a different species altogether, like porcine or pig skin used as a temporary biological dressing for burns.
Okay, beyond where it comes from, the text makes a really big deal about the thickness. Split thickness versus full thickness grafts.
This is huge because it dictates how both the wound and the donor site heal. A split thickness graft takes the epidermis and only a fraction of the underlying dermis.
Meaning you leave the deep dermal appendages like the hair follicles and the deep sweat glands intact at the donor site, which allows the place you took the skin from to actually heal on its own by regenerating. This makes split thickness grafts amazing when you need a massive amount of skin, like for a severe burn, because you can just harvest from the thigh and the thigh will heal itself.
Exactly. But a full thickness graft takes the epidermis and the entire dermis. Because you've stripped away all those regenerative appendages, that donor site cannot heal on its own.
Oh, so you create a new problem.
You've created a secondary wound that requires surgical suturing. This severely limits your available donor areas to places with redundant loose skin that can be pinched and closed together, like the groin or the postauricular area behind the ear.
So a graft is tissue moved without a blood supply. It's like planting grass seed. The soil underneath has to be perfectly wet and fertile for those seeds to imbibe nutrients and take root. But what if the soil is terrible?
If the soil is bad, then you need a flap. A flap is a unit of tissue moved from a donor site to a recipient site, with its vascular supply, its artery and vein kept entirely intact.
Following the landscaping analogy, a flap is like taking a massive crane and transplanting a fully grown tree, along with its entire root ball and a functioning irrigation hose.
Yes.
Because you brought your own water supply, you can plant that tree on solid rock.
And in surgery, if we connect this to the bigger picture, that solid rock is exposed bone, exposed tendon, or heavily irradiated tissue. Grafts will simply die there. You must bring in a vascularized flap.
Right.
And for the MRCS exam, you don't just need to know the concept. You have to memorize the specific, reliable anatomical arteries that keep these flaps alive. The text lists 5 really high-yield examples.
Let's visualize them, because just memorizing a list of arteries is brutal.
Okay, think about the anatomy. First, the radial forearm flap. This is a paddle of skin harvested from the forearm, kept alive by perforating branches from the underlying radial artery.
Makes sense.
Second is the lateral arm flap, fed by the posterior collateral radial artery. Third is the anterolateral thigh flap, or ALT flap, based on branches of the lateral femoral circumflex artery.
And what about the massive ones? Like for breast reconstruction after a mastectomy. I know they move a lot of tissue for that.
For that, you use a tram flap. That's taking skin and muscle from the lower abdomen. It survives on the inferior epigastric artery. And finally, the latissimus dorsi flap.
That's the back muscle, right?
Yeah, this is where you literally detach the large back muscle and tunnel it under the armpit to the front of the chest. It survives because the surgeon meticulously preserves its main blood supply, the thoracodorsal artery.
It's just astounding. You are rerouting human plumbing in real time. Okay, we've identified the threats, staged them, and we know our reconstructive tools, the seeds of the graft versus the roots of the flap. Now let's open the surgical playbook.
Time for the real-world scenarios.
Right, the text gives us these messy trauma scenarios to test this logic. But let's quickly define how we close wounds before the patients even roll into the ER.
Okay, so the three types of closure are driven almost entirely by the bacterial load. Primary closure is straightforward direct apposition. The wound is clean, you just stitch the edges together. Done.
Simple.
Delayed primary closure is used when you fear an infection might be brewing. The text notes this is critical for patients on steroids or diabetics who have impaired immune responses.
What's the cellular logic there? Like, why delay it?
Because if you stitch a contaminated wound shut immediately, you basically trap bacteria inside a dark, warm environment. It becomes a massive abscess.
Eeks.
Yeah. By leaving it open for a few days, you allow the patient's macrophages to clean the wound bed. Once the bacterial load drops and healthy granulation tissue appears, then you surgically close it.
And then there's secondary intention where you don't stitch it at all. You leave it completely open to heal from the base up. You use this for severe infections, like a ruptured abscess where sealing the roof would just be catastrophic.
Exactly.
All right, let's hit the text-specific clinical scenarios. Scenario 1, a dirty laceration to the scalp.
So the scalp is highly vascular. It bleeds profusely, but that robust blood supply means immune cells flood the area quickly. So even if it's dirty, you can usually wash it and use primary closure.
Well, what if it's really bad?
Well, if there is actual tissue loss and the periosteum, the vascular membrane covering the skull bone, is scraped away, you have a major problem. You are down to bare, dry bone.
Bad soil. Grass seeds won't grow. A graft will die.
Exactly. You must use a rotational flap, moving nearby scalp tissue with its intact blood supply over the exposed bone.
Okay, scenario 2, a pretibial laceration. Someone severely whacks their shin.
This depends entirely on the depth. If the shin bone isn't exposed, you have decent soil. The text recommends debriding the wound and using a VAC, a vacuum-assisted closure.
What is a VAC actually doing mechanically to the tissue?
It applies continuous negative pressure. This physically draws the wound edges together, constantly suctions away infectious fluid, and this is the cool part, the mechanical microstrain on the cells actually stimulates localized blood flow and rapid cell division.
Oh, wow. So it preps a beautiful, fertile bed.
Yes. Then you apply a delayed split-thickness graft. But if the shin bone is exposed, bad soil again. You must elevate a local muscle flap.
Got it. Scenario 3 is visceral, a dog bite to the nose.
Animal mouths are teeming with dangerous pathogens like Pasteurella. If you close that primarily, you are trapping a severe, flesh-eating infection in the middle of the face, literally inches from the brain.
That sounds terrifying.
It is. The protocol is immediate, aggressive debridement, and you let it heal by secondary intention.
Just leave it completely open until the body declares victory over the bacteria.
Precisely. Once it's clean and granulating, you perform a definitive repair using a pedicle flap.
Let's define that, a pedicle flap.
A pedicle flap is a flap that remains attached to its original blood supply at the pedicle while the paddle of tissue is pivoted or rotated over the wound. For a nose, you might take a flap of skin from the forehead, pivot it down on an artery between the eyes, and suture it to the nose.
Wow. Okay, scenario 4, major burns.
For massive 3rd and 4th degree burns, you need to cover a vast surface area quickly to stop fluid loss and infection. You harvest a split-thickness graft, and you mesh it.
Meshing is where you run the skin through a machine that cuts tiny, staggered slits into it, right? Allowing it to stretch out like a net.
Yes, exactly.
It lets a small piece of donor skin cover a huge defect. But the text makes a huge exception here. You mesh grafts everywhere on the body except the face. Why is that?
Because as that net heals, the spaces between the slits fill in with scar tissue, leaving a permanent, highly visible snakeskin pattern.
Oh, man.
Yeah, that is an acceptable trade-off on a thigh or a torso to save a patient's life. But on the face, the cosmetic and psychological outcome is paramount. For facial burns, the surgeon takes the hit on donor site morbidity and uses a solid, unmeshed, full-thickness sheet of skin to ensure a smooth, natural-looking result.
It is a relentless series of physical compromises and logical deductions. So what does this all mean? Mapping out this MRCS chapter proves our original point. Plastic surgery is architectural problem solving.
Yep.
You learn to identify the squatter from the Vandal BCC versus SCC. You respect the deep 3D thread of melanoma by measuring its Breslow thickness. You choose your biopsy tool precisely so you don't ruin the staging evidence. You decide if your wound needs the imbibing grass seeds of a graft or the heavy-duty vascularized root system of a flap. And you apply that exact cellular logic to scalps, shins, and burns.
It is a remarkable discipline, and as we wrap up this review, there's a tiny, almost hidden detail in the text that points to where this entire field is going.
Oh, what's that?
In the section discussing hand anatomy, the text notes that a human fingernail grows at a rate of exactly 0.1 millimeters a day. It's constantly, endlessly regenerating from the specialized stem cells in the germinal matrix of the nail bed.
0.1 millimeters a day, just relentless cellular factory work.
Exactly. And earlier we discussed xenografts, how we can temporarily interface porcine tissue with human wounds. When you combine those concepts of growing mastery of tissue engineering and the body's inherent ability to endlessly regenerate complex, multi-layered structures from stem cells,
it raises a massive question.
right. Are we approaching an era where this entire surgical ladder of grafts and flaps becomes completely obsolete? Will there be a time when we no longer need to harvest a massive latissimus dorsi muscle, creating a second surgical wound just to fix the first?
Yeah, will we eventually just paint a massive defect with a synthetic bioengineered matrix that commands the body to regrow its own complex dermis, fat, and vasculature from scratch, exactly like a nail regenerating from its bed?
That's a fascinating thought.
That is absolutely wild to think about. We'd go from moving trees around with a crane to just telling the earth to grow an entirely new forest on command. Thank you, the listener, for joining us on this deep dive into the MRCS plastic surgery chapter. Keep studying this matrix, keep pushing to understand the why behind the what, and good luck with the logic puzzles on your exam.